So we are going to back to the proposed position statement and with amendments. Thank you for working on that during your lunchtime, Gary.
Well, we talked about how, we just need to know that we open it. They're gonna approve the language, but we're gonna show them that when you document, right, I'm gonna go back to the document first, but when we put this on our website, all of this is hyperlinked. So these just click on those links. But I have an active resource. So I already know this.
Stefan Runyon, we can pull up the original document and speaking specifically to board member Kirkbride's comment, the reference document is actually hyperlinked, so we can pull that up and indicate where that was referenced. So it's reference number 4 in the document. I think we indicate at the bottom also it's pages 8 and 9.
That's page 8 right here.
And it's the very bottom paragraph there, which in the position statement, it's represented as 3 bullet points. And it reads, however, if a prescription identifies only a patient name, drug product formulation, this would not be sufficient to establish the prescriber made the determination is described by section 503A(b)(2), et cetera. So all of those points are referenced and directly lifted from that document there that's hyperlinked to reference number 4.
Can we go back to the position statement? Just
Sure.
checking.
Yep, give me just a moment. Here you go. Am I in the right?
Scroll up.
It's right here. Or here.
Scroll up a little more so you can see.
Oh,
Previous page.
And then reference 4,
oh, reference.
So
down the bottom.
Here.
and so that's the
Okay.
link that she just clicked. Where we got that.
We need to go back to the other document. Still looking at that. We need to go- So what is it they're wanting to read? There's something I can paste.
Staff member Runyon, could we didn't add the requested language over lunch. Could we revisit this after one of the upcoming presentations to include the language reference from Washington's document, including the link that board member Kroger mentioned?
We can, or we can go ahead and just approve it as amended and put it in there. I don't know that we really need to see does anybody absolutely want to see the language from the FDA that says they're bad actors? And Rachel, board staff, Melvin showed me, on the Oregon Board of Pharmacy's website that there is a public, app for consumers, and there are several things, from the FDA that people can link to, and that would be probably a place that we can also put that FDA reference, for someone who's public facing wanting to see there's some information. Thank you for doing that.
And you can also.
I don't know that we need to wait to do a motion. Does anybody else feel that we need to, or we can just do it as amended and have that added? I'm hearing head shakes, and I'm not hearing anybody on the phone disagreeing, so let's just get her done, Sir Gary.
All right, thank you, Staff member Runyon. We'll continue in that manner of direction. Staff member Runyon, President Chin, Staff member Melvin also mentioned and the possibility of sending that out as a gov delivery
Great.
message. Yeah.
Okay, thank you. I think that would be helpful because I think there are other boards on the gov delivery. Perfect. So proposed motion, is there a motion to move to adopt the position statement as amended concerning semi-glutide compounding as proposed? Or revised as I say. Who'd like to move that?
So moved, Vice President Joyce?
And Board Member Hall. Thank you. Board President Chin, yes. Board Vice President Joyce.
Yes.
Board Member Beeman.
No.
Board Member Hall. Yes. Board Member Hemmons.
No.
Board Member Kirkbride. Yes. Board Member Kroger. Yes. Board Member Patel.
Oh, give me just a moment to unmute her, please. Board Member Patel, can you unmute? Sorry.
Yeah, thank you. Yeah, thank you for unmuting me.
Sorry, I couldn't see your hand.
Okay, perfect. Board Member Patel, I don't think so. I get a chance to make a comment. If you're doing the round robin, I didn't know about that, but anyway, doesn't matter. I'm going to be opposed. Thank you.
Nader. Yes. Okay, motion passes with board members Beeman, Hemmons, and Patel opposed. Right, so thank you, everybody, for coming back from lunch, and we will have a board discussion about standard of care with staff member Runyon.
Staff member Onion yet again today. Everyone had a happy and filling and fulfilling lunch. Next, we'll discuss the standard of care, which could be the highlight of the day. We'll see. It's a highly charged topic, and with all the meetings, as I've mentioned, when I had facilitated the PFAC meeting, is a primary tenet of mine is that we don't always have to agree, but we can always treat each other with respect. And I think we're all here for the same reasons, and a dedication to the profession and passion for serving others. So as these conversations unfold, as they undoubtedly will, as we proceed through this presentation, just keep that in mind. And first I'll cover what this presentation is. This presentation is an existential journey into the realm of standard care regulatory model, where limits placed on pharmacy practice through rigid bright line regulations are dissolved and replaced only by amorphous, more adaptive and circumstantial boundaries. At its core, this regulatory model encourages adaptation of a novel equilibrium between the prescriptive and the permissive. The intent of this presentation is to equip you with the information and operative understanding you'll need to engage in constructive discourse, both with other board members internally and other healthcare professionals externally. And next, I'll cover what this presentation is not. This presentation is neither an endorsement nor a repudiation. Instead, it represents a supportive neutrality. The assignment of judgment and evaluation of applicability are for you and you alone as board members. Any criticisms herein are simply byproducts of deconstructing the arguments for focal scrutinization and should not be construed to represent bias. And finally, this presentation is not intended to diagnose, treat, cure, or prevent any disease. But depending on which side of the fence you're on, it could raise your blood pressure a little bit. So. All right, next slide. All right, so we'll start out with covering some definitions here so that we can start out on the same page. We may not end up there. We can start out there. So you hear the term bright line regulation mentioned a lot. And an easy way to remember this is just imagine there was a bright line around this box, maybe like a neon green or blue, if you prefer. That would create a boundary between everything that's in the box and outside of the box. And so here, a bright line regulation is an objective rule that resolves a legal issue in a straightforward, predictable manner. It's easy to administer and leaves little room for varying interpretation. So in terms of how that might exist or be exemplified in the pharmacy world, maybe a strict quantity limit on controlled substance prescriptions, so limiting the amount of refills that's allowed for a C3, for example, a maximum refill count on certain scheduled medications, a definitive age limit for purchasing OTC medications like Sudafed, et cetera. So there's nothing left to interpretation. Either something is or it isn't within the box or outside of it. And something else you'll commonly hear is right touch regulation. I call this the Goldilocks regulation. It is prescriptive, but it's circumstance specific. So it's a regulatory decision made or a regulatory making approach that uses a minimum amount of regulations needed to achieve a desired outcome. So in this instance, it would represent assessing the level of risk of the public and then responding in a proportionate and effective way, and that's targeted and outcome oriented. So it's not overly prescriptive, but it is appropriate depending on what target outcome is identified. So what are examples of that? DUR flags. A DUR flag that is more targeted might only show up if it's related to a significant risk. And those, might show up as red on the screen, or different operating softwares will project those in varying ways. So in that way, you're not, what's the difference? We're not flagging everything that could potentially cause a rash, right? They just create white noise, and every medication in existence can cause rash. So that's an example where discretion might be applied to create a right touch regulation that identifies a subpopulation or a subgroup of the target that's associated with high risk. And counseling, for example, in our counseling rules, we allow the pharmacist to determine the manner and amount of counseling that is reasonable and necessary under the circumstance to promote safe and effective use or administration of the drug or device, and to facilitate an appropriate therapeutic outcome for the patient. And so in that way as well, you could construe that to represent something similar to a right touch regulation. All right, so the standard of care regulatory model is determined by individual circumstances that present practice rather than specific requirements codified in law, allowing for flexibility as practice guidelines change, as technology changes and new knowledge is identified. And this model therefore requires less regulatory modification to keep pace with the change. And in this model, a licensee or registrant may consider all the following. So these are going to decide or guide the decision-making process: whether the performance of the act is expressly prohibited by provision of rules or in the chapter, whether it's prohibited by rule adopted by the board, whether it is consistent with the education, training, and experience. You'll hear that quite a bit. Education, training, and experience of licensee or registrant. And then whether it's within the accepted standard of care that will be provided in a similar setting by a reasonable and prudent licensee or registrant with similar education, training, and experience. And this is also in line, as we'll see in a later slide, with verbiage that's present in the standard of care language for physicians, nurses, et cetera. So in general, standard of care regulations, just to generalize, they do not require frequent reviews and updates. And that enables a more innovative approach to practice, which can also translate to enhanced patient care and safety in some instances. Standard of care, or SOC, regulations are permissive in nature and depend, again, on the individual circumstances present rather than rigid prescriptive laws that do not change. So ideally, changes in rules to an SOC model would be accompanied by corresponding changes to unprofessional conduct and further stratifying what that means or what it would look like. In this way, certain things that pharmacists may do could potentially change depending on the situation. But certain things a pharmacist may not do could potentially be universally applicable regardless of circumstance. And a few more definitions. Scope of practice, we're all relatively familiar with that. The services a qualified healthcare professional provide that's deemed to be competent to perform and permitted to undertake in keeping with the terms of their professional licensure. Education, training, and experience, again, a buzzword you'll hear throughout this presentation. The accumulated knowledge, skills, and practice gained through formal education, professional training, and hands-on work in a particular field. And another thing you'll hear quite often, reasonable and prudent licensee or registrant. So it's a healthcare professional who's deemed to be sensible and careful in their actions, possessing similar qualifications and acting within the scope of their practice. And in this slide, we'll start to talk about the why. In other words, why is anyone interested in moving to a more progressive model, if you will, such as the standard of care regulatory model? In a standard of care regulatory model, bright line regulations, as we discussed earlier, are essentially eliminated, meaning that instead of strict, clearly defined rules dictating what a pharmacist can and cannot do, the practice is guided by a broader principle of providing the level of care that a reasonable and prudent pharmacist would exercise in similar circumstances, allowing for greater flexibility and adaptation to individual patient needs and evolving practice situations. So key points about the shift. It favors flexibility over rigidity. A standard of care model moves away again from bright line regulations, which often create barriers to optimal care, but by being inflexible and not accounting for unique situations. Standard of care model also values professional judgment. Pharmacists are expected to use their clinical judgment and training to make decisions based on specific patient needs, rather than being limited by strict rules. And the standard of care model also encourages or confers an adaptability to change. This model allows for easier adaptation to new technologies, practice advancements, and evolving healthcare needs. And an example of a standard of care regulation within a particular facet of the practice, we talk about drug substitutions. Instead of a strict list of medications that can be automatically substituted, a pharmacist could use their professional judgment to determine appropriate substitutions based on the individual patient's needs and medical history. So for example, if I were to get a patient that brought a prescription for simvastatin and that wasn't covered on the insurance, instead of having a restrictive model indicating what medications I could substitute for that, I might be able to choose on my own, and that may not even be limited to another statin and perhaps another cholesterol lowering medication in a different class, could be appropriate if that's determined. So again, it's restrictive in the sense that it's isolated to a particular facet of practice or has a focal application, but it's permissive in the sense that with that confine, there aren't any boundaries. So you'll see this model or this graph quite a bit if you go to any conferences or you go to any lectures, webinars, etc., where this is talked about. And so this is a kind of a personal adaptation based off what I've seen. So what is this? We have 5 pharmacists here represented by the bars. We have in the orange there, the traditional standard of practice, or what would be considered the top of someone's license. And we hear that quite a bit. We want pharmacists to practice at the top of their licensure. So that would be represented by the orange. And you see that it's rigid, it's not adaptive, it's universal, it doesn't change from scenario to scenario. And then we have the standard of care in black. And you can see it is adaptive in the sense that it responds to essentially what is each individual pharmacist's education, training, and experience. And because the income in that situation is different, the outcome might also be different. So it is worth noting that the standard of care can change. And what would that mean to the patient in terms of the level of care that they're going to get? And one last thing I'll point out here is the very base of, I think it's purple, where you see barrier of entry into the profession. One thing I'll point out is that's oftentimes construed or communicated to represent the baseline level of competency. However, I feel it's incongruent to compare those two. The barrier of entry into the profession really is a credentialing issue and actually doesn't represent, in my opinion, it doesn't represent a level of practice. You can't practice until you're in the profession. So conflating that to a minimum level of practice when it's actually a credentialing issue, I think can potentially be problematic. Also, this standard of care graph really focuses a lot on the top end and what people do in a progressive way to provide patient care that may not be supported by traditional regulatory means or approach. But if you take a look at all of the things that you've seen in terms of patient cases or in terms of cases in the board meeting, over the last, however long you've been here, or over the last couple of years, I think that begs the question we have to ask ourselves: are these cases related to people that are practicing at the top of their licensure, or are they related to arguably pharmacists practicing at the bottom? Are these cases more often related to a pharmacist perhaps doing something at the top of their licensure that maybe they shouldn't, or maybe it's a little too progressive and not supported in rule? Or are they more likely to be related to a pharmacist at the bottom, that's practicing at the bottom of the licensure, that's not doing something they should? I think that should be entertained, and we'll cover that at the very end as well. And I'll leave you with several questions to kind of open up the floor to dialogue. One additional thing, I think this is a good segue into the safe pharmacy practice conditions. And we'll talk about one last thing on this slide. Again, we focus so much on the ceiling here, right? And we're talking about progressive approaches to care and expanding the scope of practice for pharmacists. But I beg you to consider, how can we, and again, this is just a question for your consideration. It's not for me to answer, but certainly one I think that's worth entertaining. How can we expand the scope of practice when pharmacists are unable to provide even the most basic of services that we would arguably put at the bottom of this chart, such as answering the phone, such as counseling patients in an appropriate manner, such as providing refills in a timely manner? Those are all basic things that if you read through the SPPC survey results, you'll find that our pharmacists on the front lines are actually having a difficult time completing or executing. So while I do appreciate the spirit of expanding the scope of practice, I was talking to a staff member and I made this kind of silly analogy, as you'll come to learn, that I'm kind of known for. But it's kind of like you're in your house and you're looking at, these little swatches. You're trying to figure out what color to paint your attic when your basement's on fire, right? You can't build on something if you don't have a solid foundation. And so, I think you use that kind of silly analogy in this context and to kind of look at that in a different way. And again, how can we expand the scope of practice in this progressive way when our pharmacists aren't even equipped to provide the most basic of services? And here are again a few definitions of the standard of care, regulatory approaches across the board. The NABP established a task force in 2018 to help states explore the feasibility of developing regulations based on standard of care rather than the more prescriptive rule-based regulations. This paradigm, should be noted, will play out over many years, but states may be able to draw from the experiences of Idaho, which we'll cover in depth, As the state undertook a major regulatory reform initiative to modernize its laws in this fashion in 2017. And the Idaho Board of Pharmacy recognized that many of its laws had become outdated and disconnected from public safety and instead stifled the emergence of new technology or practice models that could improve patient care. So we looked at NABP's definition. Standard of care means the degree of care a prudent and reasonable licensee or registrant with similar education, training, and experience will exercise under similar circumstances. The OMB or Oregon Medical Board's definition parallels that, the degree of care, skill, and diligence that is used by ordinarily careful physicians, and the same for similar circumstances in the community of the physician or a similar community. And then Idaho Board of Pharmacies definitions, a standard of care that would be provided in a similar setting by a reasonable and prudent licensee or registrant with similar education, training, and experience. So we often compare standard of care regulatory models in the pharmacy world to those in other healthcare professions, such as MDs, PAs, nurses, etc. There are a few differences I think we should note. Unlike other health professional licensing boards, the Board of Pharmacy strictly regulates the drug supply chain, the physical pharmacy location, and the individual pharmacist. And this creates an overlap in culpability between the practitioner and the outlet, which, as you know, can complicate the enforcement process, especially when it comes to assigning fault. And historically, pharmacy law has had an extensive focus on facility standards, whereas this category is not typically addressed in medical or nursing laws. And this is primarily because the accreditation by private organizations has become the leading mechanism for regulating facilities in the medical and nursing professions, whereas pharmacy has generally deferred to state laws for that regulation. And we mentioned the NABP through that task force. And the standard of care regulations are covered in the August 2024 Model State Pharmacy Act and Model Rules Act, or the Model Act. Then we have a few states that currently have standard of care regulations here in the States. Iowa is, I believe they've adopted it, and we'll cover that in a later slide as well. They've got a webinar, I believe, coming up at the end of the month, and I think it's free if you're interested in some off the clock information on that and additional insight. Might be a good thing for you to look at. Canada is also included there, and then as I mentioned earlier, with the drug substitution, there are other states that have broadened pharmacist authority within a particular facet of pharmacy practice using this regulatory approach. So, for example, pharmacists in Washington State and California may use professional judgment to make what they call adaptive changes to a prescription under certain circumstances. So an example of that is a Washington pharmacist with patient consent may adapt drugs as specified in rule, and providing that the prescriber is not indicated that adaptation is not permitted. So they're allowed to change the quantity under certain circumstances, and it doesn't say what to. Change dosage form, doesn't say what to, so no limits within that confine, and then complete missing information. Again, it doesn't say what type or place any restrictions on that. So those are just some examples of how standard of care regulations or that approach can be focally applied where appropriate within a specific set of rules. Okay, so here is the leading state in this, or the first state to adopt this model. And we all know that pharmacy is, the profession of pharmacy is among the most regulated of professions, especially when compared to medicine, nursing, etc. If you look at the practice acts themselves or the board rules, by and large, very consistently, your pharmacy rules are going to have a larger overall word count, more restrictions, more amendments, and they're reviewed more frequently, etc. The Idaho Board of Pharmacy has made this transition to a standard of care approach with an emphasis on revamping and cutting down on these laws and making everything more concise. especially as it related to professional practice standards and facility standards. Again, the Idaho approach is more permissive and essentially allows for experimentation with new practice models without first having to lobby the legislature for updates to the regulations. And under this model, Idaho pharmacists can independently prescribe medications, order and interpret lab tests, administer medications, adapt prescriptions, and provide other value-added services. And to accomplish this, the board adopted a formal rule specifying that an act is allowed to be performed by pharmacists, even if it is not expressly prohibited by any state or federal law, and if it meets the following two criteria. The act is consistent with the pharmacist's education, training, and experience, and performance of the act is within the accepted standard of care that would be provided in a similar setting by a reasonable and prudent pharmacist with similar education, training, and experience. So here we have a standard of care report. This is a report to the state legislature by the California State Board of Pharmacy. The California Board of Pharmacy sought feedback on a proposed transition to standard of care enforcement model from various stakeholders. So they formed an ad hoc committee, which met 6 times, and there were a variety of stakeholders that provided testimony. This, of course, is available anywhere Google is found, which is how I ran across this. And it's, I believe the document itself is over 900 pages. There are only about 40 or 50 pages of what I would consider, position statements or statements on behalf of the committee itself. And the remainder of it's just a transcription of the testimony. But it is good offline reading if you want to see what some of these other players or stakeholders or interested parties have to say. And we'll go over 4 of them kind of in depth, and you'll see commonalities between all of them, which will eventually feed into the questions that I'll leave you with at the end. So we'll look at feedback from the California Advancing Pharmacy Practice Working Group, California Pharmacists Association, I believe the executive director of Cedars-Sinai Medical Center, and the UFCW, or the United Food and Commercial Workers Union. All right, so we'll start with the California Advancing Pharmacy Practice Working Group. Dr. Daniel Robinson headed that work group and made a few key points about this regulatory model. Of note, they used the term statutory handcuffs. He deemed those provisions in law, such as those requiring approval of regulations by both the medical board and the Board of Pharmacy for pharmacists to furnish certain medications. And they limit pharmacists' ability to practice, again, at the top of their license. They identified that there are challenges with current scope of practice, that changes in the legal scope of practice require legislative and regulatory action, and those can be slow, adversarial, and costly. And he argued that standard of care model would create a regulatory environment that maximizes the ability of pharmacists to function as healthcare providers. And we have next the California Advancing Pharmacy Practice Working Group. Again, the advantages of a standard care model: it utilizes the full competence and ability of the health professional. And the scope of practice is determined by education, training, and experience, recognizes professional heterogeneity, advances with new education, technology, science, and practice standards. It would avoid tying fixed regulations to an entire class of health professionals, and it avoids lengthy statutory and regulatory changes as practice and healthcare evolve. The California Pharmacists Association also weighed in on the issue. Of note, they argued that a standard of care model would allow pharmacists to practice again at the top of their license. It would increase access to healthcare services and improve outcomes for patients. It would allow the Board of Pharmacy to establish a clear framework for the oversight, regulation, and enforcement of direct patient care activities and services. And it would allow the board to create an appropriate regulatory framework for patient care related to the public and protecting the public. And next we have Dr. Rita Shane, and this is the Vice President and Chief Pharmacy Officer at Cedars-Sinai Medical Center. Points of interest from this presentation include identifying or highlighting the complexity of patient care, the fact that it's growing, and all the while access is decreasing. She highlighted that there's an increasing number of patients that have multiple chronic conditions. And there's a need to advance pharmacy practice to benefit patient care in a way that is safe, effective, and leverages the knowledge and skills of pharmacists. She also identified that standard of care model would allow pharmacists to practice, again, at the top of their license and would improve patient care. And along with that, there are some complementary barriers that were identified to implementing a standard of care regulatory model. Pharmacy practice evolves faster than statutes and regulations can be updated, and businesses may not be supportive of a standard of care model. Also, insurance may play in the mix as well in terms of who recognizes pharmacists as providers and what services they're allowed to provide, etc. And she identified also that there is a need for more education and training on the standard of care model. There's a need for more clarity on how this model would be implemented. And there's more data needed on the impact of standard of care model in terms of patient care and safety. And one of the last sources of input we'll consider is the United Food and Commercial Workers of UFCW union. And they had concerns about the potential impact of standard of care model on the working conditions of pharmacists, as alluded to earlier as a result of the SPPC survey. They had concerns about adopting standard of care regulations without adequate safeguards to protect the working conditions of pharmacists. It concerns about the potential impact of this model and the fact that there's a potential variation in quality from site to site, which we mentioned earlier as well. Okay, all of that said, we'll move on to just a very brief overview of an approach to implementing a standard of care model. Again, the idea here is just to give you a brief overview of what sort of changes or sorts of changes that will be necessary and what sort of timeline that might involve. So again, the Idaho Board of Pharmacy recognized that many of its laws have become outdated and disconnected from public safety, and instead stifle the emergency of new technology and practice models that could improve patient care. And the board sought to update its professional practice standards by transitioning to a standard of care model of regulation. And in the context of medical regulation, again, the standard of care refers to that which a minimally competent physician in the same field would do under similar circumstances. It's permissive in nature and dependent upon the individual circumstance that's present rather than on prescriptive laws. And thus the standard care approach naturally evolves with new evidence, education, training, and technology, and does not need constant legislative or regulatory updates. Don't spend too much time on this since we're not voting on anything today. Step one would be to adopt a broad definition of the practice of pharmacy. So it's located in ORS 689 for us. And step two is allow for elasticity of scope of practice over time. So realizing that this is not, a 6-month or even a 1-year overhaul. And then we have to support pharmacists in the interim period as these changes are being instituted incrementally. And step 3 would be to decide which limited instances still necessitate prescriptive regulation. So again, realizing that there's a difference between regulating patient care services or clinical operations and then operations themselves, such as C2 quarterly reconciliations, such as temperature monitoring, etc. So realizing the distinction between those two and identifying instances where the standard of care regulatory model may be appropriate and where it may not. And step 4, we have eliminate all unnecessary regulations. And lastly, strengthen accountability mechanisms and oversight. And here's a sample timeline. So I mentioned previously, this is not a short-term goal. So Iowa in 2024, Governor Kim Reynolds signed HF 555 to modernize the Iowa Pharmacy Practice Act for the first time since 1986. And the bill implements a standard of care regulatory model and removes burdensome restrictions on the practice of pharmacy. And the bill goes into effect July 1st, or went into effect July 1st, 2024, followed by a form of Board of Pharmacy rulemaking in 2024 and early 2025, which will align the practice of pharmacists with their full training and education experience for years to come. So looking there, we see the initial steps in 2019. And the rule writing has taken place, looks like in fall of 2024. And it looks like they'll be live here sometime very soon. Again, the webinar is at the end of the month if you want to check that out. And again, it's mentioned in several instances that legislative overhaul will be required, which is the case here. So if we look in 689151, parent 3, the board is responsible for the determination and issuance of standards based on nationally recognized standards of practice. So that's something that would need modified. And when it was written, obviously I don't think it took into account that this is an emerging movement. And at this point in time, it's represented by a minority of states. So the verbiage in there talking about nationally recognized standards of practice, I think would be potentially an issue. And I'll just give a brief overview of some of the benefits and risk associated with either model, and then we'll finish up with some questions. So the standard of care model benefits include more adaptable, flexible, reduces the need for constant legal and regulatory updates. Licensees are required to learn and follow fewer laws and regulations. The risk of this model is less explicit guidance for practitioners, and they cause doubts about what is and what is not permissible. It can lead to a battle of financial resources between the board and the licensees. So think of if something goes to hearing, who determines the standard of practice? You'd have to employ an expert witness to help determine that, and those can be costly. And essentially, there may be a lot of instances where you would have to do that as it's circumstance specific, and whereas our rules, in a lot of instances, especially the bright line regulations, dictate or determine the standard, but that would change. So there would be a constant need if things go to hearing for that back and forth. It may result in different standards of care, again, depending on the practice setting. May reflect the competing interests considered by the legislature, or it may not, rather. And the big thing here is currently there's no data on the impact to patient safety. And then the regulatory model we currently have, the more prevalent one, and the benefits include it provides clear, straightforward, and explicit guidelines. It ensures that all licensees follow the same rules and promotes consistency and standards for all patients. In other words, the standard of care doesn't change from location to location, prescriber to prescriber, et cetera. It allows for stakeholder engagement, a statutory rulemaking process, and then the risks and the laws can become outdated and a barrier to rapidly evolving pharmacy practice. And then updating laws and regulations can be time consuming. Staff and run-ins, fair question. Okay, so I'll leave you with some questions for your consideration, and you may have developed your own. Are you in favor of or opposed to standard of care regulation? And if so, what are the primary drivers of your opinions? Did this change at all from your previous answer if I were to have asked you at the beginning of the presentation, why or why not? In other words, does your answer start with something related to pharmacist needs, or is it something related to patient needs? Is it somewhere in between? Does it involve both, etc.? It's just a question to help you identify the root of what your where your opinion lies. And should this be an all or nothing decision? Most often when we refer to adopting standard of care regulations, what it means or what people mean by that is it is an all or nothing thing. So they're completely dropping most all bright line regulations. So that's good to understand in the context of conversations you might have outside of the board here. And in that vein, what kind of model makes the most sense? And whom should it involve? Idaho currently allows the pharmacist to delegate tasks to the technician, and essentially without boundaries, and they're allowed to determine, again, the technician's scope of practice, which is related to the technician's degree of education, training, and experience. So whom should those regulations involve? Pharmacists only, technicians, drug outlets as well? And I've already alluded to the fact that standard of care regulations are in several ways related to safe pharmacy practice conditions. And with just a few more questions you might consider. Which rules do you feel are too prescriptive and why? And we've heard that mentioned today. So from what vantage point are we making that assertion? And is it from the standpoint or perspective of a pharmacist? How does that relate to patient safety? How do these prescriptive rules affect the board and the outlet? And how would the abolishment of those affect the board, the outlet, pharmacy staff, patient safety, et cetera? And again, going back to the point that some rules are operational in nature versus clinical. So we talk about providing care versus satisfying certain operational standards, like I'd mentioned, the C2 reconciliations, the temperature monitoring, et cetera. Also relating that to a comment I made earlier about access to care. And what we're really concerned with is access to quality care and is access to safe medications. So in what instances do these operational rules have a tie to or directly affect patient safety? And then again, examining some of the most common violations that you've seen, whether over the last couple of months or a couple of years. And do these represent people practicing at the top of the licensure or at the bottom? And in this manner, understanding that impact, how would removing the baseline requirements or standards enhance or sustain patient safety? And lastly, there are no current studies that characterize the impact of standard of care regulations on patient safety. And because these boards typically only investigate complaints that come in due to violations of the standard of care and professional conduct, and not in the same manner that we do. So there are markedly fewer cases that these boards see, and therefore, and again, this is my personal conjecture, when you're reducing those data points, it would be inclined to make the argument that because there are fewer data points, that there just isn't as much breadth of data in order to make any determination as to what the impact on patient safety might be. And then lastly, something that's not up here in terms of the questions, I have gotten feedback from being out in the public and again, other sources like being on phone duty, interacting with interested parties at presentations and what have you. And so what I've heard more than once is that in some instances, pharmacists or licensees are confused about what we expect from them. Generalized statement. And I would encourage you to consider that if that's the case, and that represents a majority opinion, then how would removing explicit rules affect their perception of being able to determine what they expect from us and what they don't? And with that, I will open it up to you, President Chen.
So, this is mostly an informational light on what standard of care practice is. Happy to hear comments, but there is no decision being made today. It started with Member Kirkbride last time, so we can go to Board Member Kroger.
Thank you, President Chen. Board Member Kroger. Thank you, Gary, for the time you put into this presentation. I have a lot of thoughts on this, but trying to be succinct here. I think one, I wanted to, the comment made around why expanding scope of practice when pharmacists can't complete their basic duties, or we have a feeling that they can't complete their basic duties. I have trouble with that statement. I'm sorry. That is not the point of standard of care. And I think that's a leading statement. And I know you started off with saying that this was kind of meant to be presented in an unbiased way, that it was informational only, but I don't feel like this was an unbiased informational only presentation, unfortunately, the way it was. I still appreciate the time you put into this. But I think that as we look as a board into how are we reviewing the crafted regulations by board staff, understanding what is and what is not standard of care, I think was the point of this discussion, not to debate the qualities necessarily, but so that we can form our own opinions based off of the experts that are out there when it comes to standard of care that's already been implemented. The other thing I would just like to add is there's a lot in this presentation, a lot to digest for myself, and I presume the other board members, and to be put, literally on the spot in this moment to give my gut reaction is not what I as a professional typically do. I try and refrain from gut reactions. I want to be methodical and thoughtful, and have time to really digest the information before being asked, what is my opinion on this? So I have concerns with that. Data on patient safety related to standard of care. And I asked this, and I could be completely wrong. Is there also data to support the regulatory model for patient safety? Are there studies related to that, right? I understand there's a lack for standard of care, but is there also on the flip side? And I think that in my interactions with the public and pharmacists, the confused on what the board expects from them. In my opinion, I believe the confusion lies within how cases, questions, investigations are conducted, and not necessarily on what the rules are. It's how the rules are being interpreted by when they're being inspected. So those are really my thoughts on that. I think standard of care And the beauty of standard of care when it comes to if a pharmacist can't complete their basic duties, standard of care would be, they can't do other, they need to, that should be their decision to, no, I'm not going to perform prescriptive authority or these other things that standard of care would allow, but it's the pharmacist's professional judgment to say, no, I've got these basic duties to meet. But what we're doing is we're limiting pharmacists who are in environments where they are able to perform at the top of their own expertise, knowledge. We're not allowing those pharmacists to be able to provide the care to patients if we limit them. So it isn't just, hey, everybody can do whatever they want, no matter what. This is giving pharmacists the ability to practice in the way they see fit. And I think what I am proud of in the state of Oregon and the rules that we do have, especially regarding working conditions, is that we have empowered our pharmacists to make that decision on what they can or cannot do and perform within their own pharmacies. And I think we already have that on the books. And I would not see that standard scope of practice, standard of care would deviate from that and remove the pharmacist's professional judgment, professional determination to control all aspects of pharmacy practice. Thank you.
Member Benito. Somebody had to. I know.
I have worked next to a pharmacist who did come from Idaho and who did have the experience of the standard of care model. And nothing against your views or what you have said about pharmacists and their inabilities to do simple things like answering the phone but I have worked in a lot of pharmacies. I have traveled and I have seen a lot of pharmacists who can't do that because of staffing issues, because some flat out refuse to do it. So I think it lies within the pharmacists themselves on what they deem to see as their ability to do something or within their scope of practice, or with whether or not they're able to do one thing or another. And I have also seen insurances dictate what a patient can and cannot take. And the days that it takes for a pharmacy staff, pharmacist, whomever, to contact a provider's office to get a simple change from a torvastatin to rosuvastatin, because the provider's offices are so backlogged, and then the patient is then without medication for how many days if it happens on a Friday and we can't get a hold of someone until a Tuesday. So there's so many more factors around what could change in pharmacy or what would be beneficial to pharmacists or pharmacy or patient care or Oregonians. So I do think there are parts of standard of care that would be great. And I think there are a lot of great ways as far as, having a structure and being able to know, okay, if I do this, this is what's going to happen. And having the laws and rules, even though I feel like a lot of licensees have a hard time following our laws and rules because they are so all over the place sometimes and they're not updated, and that part is difficult when it comes to, you have to listen to the FDA and you have to listen to this person and that person and all of the things that change so rapidly in pharmacy. So I don't like the thought of it being black or white, but I do think that there's a lot of room for pharmacy and pharmacists and licensees to be able to do more for our patients than what we can do now.
So, Board Member Joyce, I do like some aspects of standard of care, the amount of flexibility the pharmacist has, the amount of independence, and then it can come in handy when because with SBCC, one of the big things that we're brought up time and time again was a lack of staffing, understaffed pharmacies, and and that's one of the reasons we don't have a pharmacist to tech ratio that some other states have. So overall, Oregon, when it comes to are we on the overly prescriptive side or the permissive side, we lean towards more of the overly prescriptive side. And I do feel we need to shift that over more to a little bit more not so restrictive, not so prescriptive, and towards standard of care, that direction. For example, we have rules that we don't allow technicians to return medications to Pyxis machines. They have to go back to the pharmacy for the pharmacist to visually see it to be returned back into the Pyxis machine. And that's so time consuming. Technicians that are returning medications from a Pyxis machine, from a extent bin or return to pharmacy bin, those could easily be scanned in back into Pyxis with the use of technology that can be done safely. And because we don't allow them to be returned into Pyxis like some states do, that could be adjusted for the pharmacist to delegate a technician to be able to return medications to Pyxis machine, because we are able to use technology and other scanning devices to ensure patient safety. So that's one example where a standard of care model could support a pharmacist delegating the task of returning meds into Pyxis without the pharmacist having to visually verify it. And also open a pharmacy. It's been brought up by other board members in the past that a technician should be allowed to open a pharmacy without a pharmacist being present. That can come in handy in possibly rural areas, remote areas. I also think that the prescription, the RDSP rules and the prescription lockers are too prescriptive, and it limits the patient access because we are overly prescriptive on those rules, and those may need to be revisited down the line. So those are my main points. That I do like the flexibility to allow the pharmacist to be able to delegate more tasks to a technician with experience and practice, or experience. And those are using professional judgment, and I do allow that flexibility of that. And we do need to move more towards that direction when it comes to the practice of pharmacy. Thank you.
Board Member Patel?
Board Member Patel, I'm going to agree with Board Member Kruger said. You are right. It's not that we don't have time at the community pharmacies. It's just we are comparing orange to apple, my dear. So let's say if I'm in the community pharmacy, right? And in the retail side, if I'm going to check like 400, 500 prescription per day, you are right. I'm not going to have a time to bill for the CPT code 99215 to manage the diabetes. No. But if I'm going to be in the clinic side as a clinical pharmacist, yeah, I have a time to bill the 99215 code. It's like, it's a two different scenario. When I'm in a hospital working, it's a whole different story. So it's not that standard of care is just for the community pharmacies. It's just not that. So yeah, probably I will also get offended by that. The other thing is like about the standard of care. Here is the thing. When I attend the NABP Steering Committee for Research and Innovation, the three things we talk about is the integrated advanced technology and AI in pharmacy workflow, expand the scope of practice for pharmacists and pharmacy technician, and enhance clinical education standard in the pharmacy program. Those are the what 3 topics we are talking about, right? In research and innovation. So according to, and here is the thing, even if you check in the ACPE standard, which is like Accreditation Council for Pharmacy Education, even they said, according, and it's called like standard 2016. The most current standards, known as a standard 2016, are organized around the 4 major sections, and it is known as a care model. So it's like fundamental knowledge, essential for pharmacy practice and care, approach to practice and care, and personal professional development. So right now, even ACPE doesn't mandate the specific diagnostic procedure, but it requires pharmacy schools to prepare graduates to deliver the direct patient care, which include physical assessment and diagnostic reasoning. So we are going that way. So there is no debate about it. Even if you check into the standard of 2025, according to accreditation standards, Accreditation Council for Pharmacy Education, even if you see that there's a clinical laboratory data section, even they said application of clinical laboratory data to disease stage management, which include the screening, diagnosis, progression, and treatment evaluation. So we are going that way. And they also talk about the patient assessment as well. So every state, you talk about all those pharmacy school nowadays, they are preparing their student for the standard of care, diagnosing and prescribing, which is 10, 15 years ago, we were stay away from those words in the pharmacy. So we are going that way. It's just we have to decide whether we want to go the rest of the other states or we want to be left behind. So that's my take on like standard of care is coming. Give us another 5 years. It will be standard in every state. And then if you want to correct, you can double check. So we had this committee meeting for research and innovation. And then there was a Canada. They are also going that way, that they want pharmacists to fill the primary care gap. You check in the England too, the Rishi Sunak, the prime minister, they give like, they I think they done the ruling and there's a 6 months of the physical assessment program for pharmacy. And then they eliminate by giving power to pharmacists to do the standard of care or the fill the gap for the primary care provider gap. They eliminate 10,000 appointments per year, 10,000 appointments. Let me tell you, in the rural Oregon, we need this because we don't have that many primary care providers. So that's my take on this. Is not for debate like whether we want or whether we don't. We should start thinking about it like how we should implement and how can we help Oregonian. Thank you.
Thank you. Board Member Hemmons.
A lot of information. I don't have anything to add.
Thank you. Board Member Beeman.
Board Member Beeman, thank you for this discussion. I greatly appreciate that this is an avenue we're looking down. It the me that was on the board when Idaho did simplify their rules was shocked by that, and I didn't know how to interpret it. The me that is on the board now and seeing a board being directed into back into too prescriptive of rules, back into the unintended consequences of having prescriptive rules in the name of clarity, though may not have provided clarity. It gets us to where we are now. I echo a lot of things that both Board Member Kroger and Board Member Patel have said. I find it horrifying that, and it is the truth, pharmacists and our part of our license and what we're doing under our license involves answering a phone when no other practitioner that I'm aware of that is in charge of the practice they're overseeing while working is the first one expected to answer the phone. And so I think that we sometimes, in the complaints we see and the cases we hear, lose sight of what are business decisions and what are actually within a pharmacist practice. And I think that this discussion and this avenue is a way to try to help correct that, because as a profession, we are extremely behind what has been put on us because of our quote unquote accessibility, to the point that we are no longer accessible anymore. I look forward to looking down this path and following the future board when I'm no longer like how this path pans out. And it fills me with a lot of hope, because the prescriptiveness within the rules has been increasingly frustrating, not just for me as a licensee, but as for other licensees that I talk to. And I just hope that we can get back to being ahead of the curve, as and more adaptive, because as Board Member Patel put it, changes are coming faster than we're able to adapt right now. And while that's always been the case, I think it's moving even faster now than when I started on the board. So thanks.
Hey, Board Member Beeman. This is Board Member Chin, and I am actually a supporter of standard of care for the profession. I'm not sure that I have a knowledge base of saying that technicians should be part of the standard of care model. Because there's such a huge difference in autonomy that pharmacists should have in their practice that don't know that techs necessarily do. And I understand the concept of each pharmacist could be able to say which tech could do what, but I'm not sure how that's regulated if there is a patient outcome that was not good. So I would just have to think all that through. Like Board Member Pro said, this is a lot on the fly, but I see extreme parallels to where nurse practitioners were years ago, having very prescriptive scope of practice, formularies. We had to jump through lots of hoops to do what now we are doing standard of care. Our model, our rules are you have to follow nursing practice and your knowledge, skills, and abilities. There are no prescriptive rules for my profession. So I am in support of that for the pharmacy profession, but not understanding the complexities of the place that we also license and the licensee. So while I'm in support, I'm looking forward to more conversation and learning more. Remember Hall.
I agree with what everyone's been saying. Feel like going towards the standard of care model would, increase patient access and improve patient safety because of the access. And I think it would also help put out the fires in the basement, so to speak. Because the pharmacists would have the ability to, make more decisions without the concerns of all these rules and move on and not have to sit and wait for days or however. And I also support utilizing our technicians at the top of their license and maybe pushing towards, having them be nationally certified and trusting that they can do certain things based on our practice.
You, and board member Cookburn.
Going last, my thoughts. Trying to remember all the questions. In general, I am a proponent of moving away from bright line regulations. Now, whether that lands somewhere in the middle, I think you called it right touch, or whether it's more standard of care, my preference would be we move in that direction. I would need to learn more to decide, where I feel strongly about where that lands. One, I think, missing piece of information, and I would be curious with Idaho, who's now been doing it for a few years, is so we have these questions about what does this do to patient safety? To me, that's like, okay, then what kind of cases are they getting now, right? So what do those cases look like? Are they fewer but more complex? Are they, what does that look like? So in order to weigh in with my board member hat on, I kind of need to get a little more information about what that looks like, whether I would want to support something that is on that end of the spectrum versus something that is more in the middle. I do think one of the questions was, are there any rules that are too prescriptive? I kind of giggled to myself going, where do I start? I think in every section of our rules, there are rules that are rightfully prescriptive and objective because they have to be, but there's a lot of rules that are unnecessarily prescriptive. And I do think it weighs down pharmacists from doing what they do best in order to meet all of the criteria and cross the T's and dot the I's. And there's a lot of places where patient care could be improved if pharmacists didn't have to meet kind of arbitrary standards in some of these rules. So I'm a proponent in general. I want to learn more. I think this is a great conversation to be had. And, I've been practicing in Oregon for 25 years and I've seen us go from being considered a very progressive state. And, when we rolled out contraceptive prescribing by pharmacists, it was like the talk of the town. At APHA and national organizations like, wow, I don't feel that way about Oregon anymore. I don't see us as being innovative, and it does feel like we are lagging a bit behind. So I would love to see us move in the other direction.
Okay, this is Bernard Sharon. I just wanted to add one point about, we can do all kinds of things to try to work on advancing or actually not limiting by virtue of rules, a person's scope, as a pharmacist, but the ability to get paid for all of that scope is a bigger question, I think, that we have no, jurisdiction over, but I think that we really need to work with, legislatures and associations on getting legislation written to get your provider status set. We're not doing it nationally through Medicare and Medicaid programs. But I know that in my profession, we were able to get, pay parity and get provider status, independent provider status. And I think that's a great place to also start working as a profession. Because no matter, you can do more and more and more stuff, but if you can't get paid for it and you can't bill for it, there's still going to be a gap. And while we're also looking at all of these things, there's a fear of my fear of, are we going to create any inequities in doing this? And I want to make sure that how we do, right, or de-prescribe or do what, or all of these things, that we're not creating environments where people who have the resources are going to get this type of care and people who don't have resources are not going to have this kind of care. So I just want to keep that in my forefront brain too. So thank you.
This is board member Patel. I just want to make sure for clarification, pharmacist or provider in the state of Oregon for the Medicaid and the commercial realm. We are just not recognized as a provider in the Part B for no
Okay,
reason. So just
so-
FYI.
Thank you. So so you are getting reimbursement from
Yes,
anybody that's not Medicare B? Okay,
that's
good
right.
to know.
Right.
Thank you.
Yep, yep.
Thank you, thank you, thank you. And I really appreciated the ACPE information. I think that when we talk about individual knowledge, skills, and abilities, there are a lot of pharmacists who haven't had, doctor of pharmacy training, in the physical assessment and diagnostic, stuff. So that later on, but I'm glad that that's being included in, models. Thank you. Now, we are going to move on to a discussion about safe pharmacy practice conditions with, staff member Runyon.
Staff member Runyon, just a moment, we're looking at the timeline for what we have left. Yeah.
We're down to, we're half hour behind.
Take a quick 5-minute break or rolling.
Yeah.
I haven't heard it. You need a break?
Staff member Runyon, I think we can continue with the safe pharmacy practice conditions presentation.
Can you just make a statement if those books are-
Great. Then take it away, sir.
Hang on, let me get it out that way. So while I'm doing that, about that. And listen for your brother.
We were thinking about a break between 3 and 3:15 in case you wanted. I will let us break. Didn't put
I mean,
the
I don't
3-minute timer on people during that discussion because it didn't feel right. I think that it was really good discussion and important topic, and we had a lot of good conversations, so thank you.
We need to make some, just say it before we start that. What else? Yeah, right.
President Chin, this is staff member Melvin. I think what we should do, since we're a little behind,
Yeah.
we told these folks for the waiver request, these 3 different organizations to be on the call if they wanted to listen, but however, I can't tell they're on the call. So I think we should just make an announcement that we will get to them after this discussion, which is set aside about 25 minutes for this particular discussion.
These are for the,
Baker County Health, Jackson County Health and Human Services, and Planned Parenthood, just in case they're on the phone.
so if, the folks from Baker County Health, Planned Parenthood, or
Jackson County
Jackson
Health and
County
Human
Health
Services.
on the call right now, we will be delayed by about 25 minutes.
Point of order, Board Member Kirkbride, that's on the agenda for tomorrow.
I think we revised the agenda.
We did, based on what happened yesterday.
Not the one that says revised. A different revised.
Correct. We did not renotice the meeting,
Okay.
but we realigned because we had time.
Our current agenda in our iPad.
It's the same one that's on our website. No. So if we were anticipating we could get to those 3 today. I'm sorry.
Including a 15-minute break at some point. So
Staff Member Runyon will take it away for hopefully more brief presentation on safe pharmacy practice conditions. And I'll just kind of give you an overview of, again, where this started, where we are today, where we might be or might go in the future, and give you a little background and to kind of prime you for follow-up conversations afterwards. So this started way back in 2012, and as the years rolled on, especially as we reached COVID, the need for this sort of thing became increasingly apparent. And to set the stage further, just imagine the scenario we're now, and the landscape of pharmacy practice continues to evolve and the scope of practice expands, while at the same time, pharmacies continue to close, enrollment in pharmacy schools continues to decline, and passing rates for the NAPLEX drop, putting an inordinate, if not insurmountable, pressure on those that remain. Accordingly, workplace conditions, to include the mental health and wellness and the employees placed within them, have perhaps never been more critical to the short and long-term viability of the profession than they are today. In February 2022, the Oregon Board of Pharmacy distributed a workload survey to all pharmacists, interns, certified Oregon pharmacy technicians, and pharmacy technicians licensed in Oregon. And the intent of the survey was to capture vital feedback from licensees on pharmacy practice conditions within the state. Capturing this data is important as safe pharmacy practice conditions have been identified as concerned by the media, licensees, state regulators, and national pharmacy organizations. For example, in 2021, the American Pharmacists Association and the National Alliance of State Pharmacy Associations jointly conducted a national survey and reported patient demands, negative abuse or relationships with employers, unrealistic workloads, and inadequate staffing are negatively contributing to patient safety. And the full results of the survey are included in the report, with respondent comments included separately in Appendix 1. And just a little demographic info. The survey was sent to 8,492 pharmacists, 783 interns, over 6,000 certified Oregon pharmacy technicians, almost 2,000 pharmacy technicians, for a total of a little over or close to 18,000 licensees. We received 2,044 responses, which represents a completion rate of about 11.5%. And moving forward, the data from the survey, it was used to inform discussions regarding safe pharmacy practices, including the work group that was formed. The board look forward to working with a broad array of stakeholders or interested parties to ensure Oregon's pharmacy professionals are working under safe pharmacy practice conditions, which is always in the best interest of the health and safety of the public. And so the majority of that was lifted from the statement that went along with the survey. And we'll go to the next slide and we'll look at some of the questions themselves. So overall, the results of the survey indicated that Oregon pharmacists and pharmacy workers have significant concerns about the safety of the workplace conditions they're subjected to. And while we won't review each question individually, they generally address a few common themes such as staffing, workload, and lack of adequate time to perform certain functions. When we're talking about the key, the black star indicates safe pharmacy practice conditions. And of the 14 condition statements, it should be noted that only one resulted in a higher positive response for a safe pharmacy practice condition. It's just a continuation of the questions. For example, I feel that my employer provides a practice environment that allows for safe and effective patient care. Job openings for my workplace are filled in a timely manner. I feel that my practice environment utilizes staff training that is site-specific, thorough, and prepares staff to provide safe and effective patient care.
What's the orange answer? Agree?
Yeah, the orange is strongly disagree or disagree. And so depending on how the question is worded, it's not a survey where yes is always a positive result, hence the stars there. And then some highlights from here. I'm given the opportunity and I'm able to take non-meal breaks throughout the workday. I feel safe voicing any workload concerns of my employer, etc. And if we just take a high-level overview of that, what we see are the trends, where the first three questions essentially involve inadequate staff or support staff. And then the next two, lack of breaks and inability to sufficiently interact with patients. So related to having an inadequate amount of time, whether for personal or professional functions. And then the other ones, lastly, inability to leverage technology and other resources such as central fill, lockers, automation, etc. And then there was another component to that. So next, the board convened a safe pharmacy practice conditions or SPPC work group to advise the board on practice conditions in pharmacies that help assure safe and timely care. These recommendations were reviewed by the board for potential changes to pharmacy regulations. And the work group held its first meeting in January 2022 and assisted in the development of a survey, which we spoke about regarding safe pharmacy practice conditions. It was then sent to the licensees, and in March and May 2022, the work group reviewed the preliminary survey data and provided comments to the board for future rulemaking. In April, board staff was provided with a preliminary copy of the survey's data. In June, staff was provided with a final copy of the survey data. And the work group met again in July and September 2022 to continue to identify and prioritize potential targets for future rulemaking and to do a high-level review of proposed rules that staff drafted. And in terms of the functions and the timeline of the SPPC work group, and you can see that highlighted here. And a little bit about the work group itself. There were 9 work group members and 2 board members. And representatives were both pharmacists and technicians from a broad variety of practice areas. And they were involved in community pharmacy chains, independent health systems, LTCs, etc. And the first project for the work group was to determine if a survey should be sent out. And obviously, we've sent out more than one survey. It looks like historically, we sent out surveys in 2011, 2013, 2016, then again in 2022. And as is customary, after that, the work group participated in a fishbone exercise, and it's also known as a cause and effect diagram. It's a visual tool used to identify potential or root causes of a problem. It helps them break down the components into smaller, more manageable constituents. And based on the components identified, it created a list of possible policy solutions that were discussed by the work group. The work group ranked the policy priorities based on perceived impact to increasing safe pharmacy practice. And the work group also reviewed, again, some possible rule language options. And we'll see the fishbone exercise in the next slide. So the work group identified equipment, technology, personnel, environment, and regulatory conditions that compromise patient safety and staff ability to practice pharmacy in the best interest of the patient. And then here's another timeline outlining the interactions between the board and SPPC. As the SPPC work group concluded its work, the board began to contemplate rules in August 2022 that align with the policies that were prioritized by the SPPC to have the greatest impact on pharmacy workplace conditions and patient safety. And the board adopted rules related to SPPC for outlets and pharmacists in February of 2023 and for technicians in August of 2023. So here's a brief overview of the policy topics. And based on the identified equipment and technology category, personnel, environment, and regulatory conditions, categories that compromise patient safety and staff's ability to practice pharmacy in the best interest of the patient. The staff developed this list of possible policies that could be addressed in rule to mitigate the concerns of the SPPC work group. The work group members ranked the policy topics based on how likely is this policy to improve the workload and or safety or pharmacy practice conditions. There is a 5-point scale with 5 being extremely likely and 1 being extremely unlikely. And you see the results there. But I've highlighted in yellow, those indicate rules related to policy topics contemplated by the board. And then the following slides will give you a few examples of what the board did with that and what specific rules were tied to those. Pharmacy closures was adopted June 2022, requiring communication with the public and reporting to board under certain circumstances, and increased transparency about closures, and hopefully in the spirit of limiting disruptions to care. In terms of lunch breaks, the outlet must provide appropriate opportunities for uninterrupted rest periods and meal breaks. In terms of pharmacist autonomy, February 2023 is an outlet must be, or may be subject to discipline for overriding or interfering with the pharmacist on duty's control of all aspects of the practice of pharmacy. And in terms of counseling, last year, March 2024, I guess we're in 2025 now. March 2024, an offer to counsel must be made by the licensee, and a refusal can be reported by the licensee. It must be a licensee to report it. An RPH may provide counseling in writing if the patient agrees. And also in February, all of these were in February or March 2023. And we talk about the discretional implementation of clinical services. It ensures sufficient staff to provide services safely. The pharmacist on duty may use discretion to halt services due to staffing concerns. And again, as was the case with the rule about RPH autonomy, the pharmacist on duty has control over all aspects of pharmacy practice. In terms of non-licensed pharmacy personnel, pharmacist is responsible for all actions of non-licensed personnel, and non-licensed personnel must not practice or assist in the practice of pharmacy. And technician tasks were also amended, and the work group liked the proposed technician rules, which it reviewed in July of 2022, adopted by the board in August 2023, and it removed the restrictions of were associated with the rigid task list, and indicated and said that techs may only assist in the practice of pharmacy. And then you'll see on the list of number 1, or on the list as number 1 related to the technology piece, was the mandate for e-prescriptions. And to date, nothing's been done on this one. In this map, I'm not sure how well you can see that. It kind of outlines the implementation of rules regulating e-prescribing mandates across the country. A few examples of legislation, of course, California, Nevada, Washington, and there are different bills associated with that that require prescribers to use e-prescriptions. And then here, the work group discussed these items after the policy topic survey results were released. But these items do not have a strong recommendation by the work group to further discuss or put effort into regulations related to these items. And while certain things have improved in terms of staffing, workload, working conditions, et cetera, it's certainly still on the forefront of everyone's consciousness. And you can see evidence of that by articles that are continuing to come out month after month that focus on these practice conditions in the pharmacy world. And just a recap, we've gone over the previous work completed by the SPPC and reviewed the top ranked policy topics identified by the SPPC work group and some current and pending regulations by other states. And I think there are several options going forward. So this again was just kind of an informational presentation to orient you as to what has happened with the work group, what came out of the work group, and see where you want to go moving forward. President Chen, I'll turn it over to you.
Into this is a presentation, are you needing direction on whether to continue with this work group? Is there still a work group? I'm actually hearing less about, say, pharmacy practice since these rules have been in place, but tell me if I'm wrong. How would you like us to go from here before I start a question and answer?
Staff member Runyon, there is currently no work group convened. So you would have to start over. Or have the direction to assemble a new one.
I think one other just quick big picture point, this was part of the board's strategic plan. So you guys had this as one of the priorities for actions to do something with the safe practice, pharmacy practice conditions. That's why we wanted just to remind the board where you've been, so you can make decisions on where you want to go in the future. So I think we're just looking for direction at all, brainstorming what the board's thoughts are, how you want to proceed.
Noted. And this was on strategic plan from 2023. For the previous
Staff member Efroff, the one that just passed April of 2024, was actually on one of the slides that board staff Runyon presented. It was part of the regulations.
Okay. Just, because I don't keep all of the pillars in my brain, so. I'm just curious, and most of what was just presented was all done prior to that strategic plan. So I'm trying to think back to the strategic plan on what we were thinking still needed to be done, but I'm gonna start that. And I would like to limit our time to try to be 3 minutes, please. Just so that we can get to what we need to with the people on the phone. Remember, Benito, you go first this time.
Remember, Benito, have these been done consistently throughout the years with the board? Or was this just, survey? Yeah, the survey, has it been consistent? Like, do the actions of previous surveys and the implements of the board, have they made a difference to start a work group if there isn't one currently? Or is this something that's kind of just a pointless act?
Staff member Runyon, could you clarify that question? Are you asking if the rules themselves have made a discernible difference in the practice conditions for pharmacists or?
Pharmacy in general, this survey is based off of pharmacists and technicians, correct?
Correct, yes.
And have the surveys previously similar to this one that had been done by the board, the outcome of doing this survey, has it made a difference in the practice of pharmacy?
I think that this is board member Chin. I think the previous one to 2022 was several years prior to that. And this was done, 2 years after COVID. And I don't know that I don't know that that's apples and oranges to me when you're thinking about that. So what is the base of your question? Is this beneficial to do?
Yes,
Would it make any difference to pharmacy practice?
because if there's no current work group and they're looking for direction on whether to continue doing a survey like this, is it?
So my take would be that the work group came up with specific things. We did rulemaking and changed rule. Question is, did that improve pharmacy practice now? And are we still hearing concerns about workplace safety? I think that's maybe what,
Based on the survey.
that survey was 2 years ago, or it's gonna be 3 years ago.
Because it takes a lot to print the surveys out and get all the information back and create all of these things and then to on what licensees are stating. So is it beneficial to continue with surveys?
But if we'll keep going around and then I'll come back to you about that. Then it might inform what you would really like to know. I think it did make a difference, the one we did, but you were working in pharmacy, things were not so in 2022. Okay, so we did the survey, we did action, we changed rules. We hopefully made a difference in pharmacy practice. I personally have not heard what we were hearing 2 years ago about, say, pharmacy practices and the numbers of pharmacies shutting down because of various reasons and not getting breaks. So I'm not saying it's a pile of cherries, but I'm not hearing the same chatter that we were hearing then. So, board member Joyce.
Board member Joyce. Yeah, I feel like, you're steering us towards, standard of care. No, but, I do know that, this was, the surveys were done shortly after COVID. And it was chaotic then. There's a lot of attrition, a lot of technicians leaving the workforce, a lot of pharmacists quitting, a lot of independent pharmacies closing. It was, I could use some words, but it was not a good time. And then so people were still kind of reacting from that, when the SPPC surveys started to that were sent out, and as people were responding to that, and we've made some adjustments as far as like we made it less restrictive for technicians to keep their license, and or to come back into pharmacy. And so since then, as far as the number of technicians since 2022 has dramatically increased. There's now every year more technicians applying and for jobs and becoming pharmacy technicians, more an increase in that. But as far as like continuing on with hearing the feedback from the licensees, I think we always should do these surveys just to get feedback and to see where we can adjust or make improvements or loosen up the prescriptiveness of rules and see where we need to go, because we do need this feedback from the licensees. We do need to hear from them about workplace conditions on a biannual basis, maybe, just so we can adjust appropriately, because a lot of this can be handled with standard of care, standard practice.
I don't want to combine those two issues.
Okay, but
we're talking about
Well-
workplace safety.
right,
Are you, so you're yes survey?
yeah,
Okay.
all right.
Sorry. Good job, thank you. Board member Patel.
Board member Patel, number one, I have no clue why the safe pharmacy practice condition presentation is still here. I thought we done with this rule. So my question to you guys is like, are we not done with this rule or we are done with this rule?
We completed what was needed to be done on the previous survey.
Okay.
Still on our strategic plan after this was done, that safe pharmacy practice conditions was still on our strategic plan of needing to be addressed. And so that's why it's being presented today. So yes, we did it. Yes, we've done it. Yes, we still have it on our strategic plan, so we have to at least address whether or not we think we want to, at this time, send out another survey.
When you say other survey, let's say for what? That did we improve by making changes in this rule? Did we improve whatever needs to be improved? Right? Like survey on what? Survey to licensee that, I don't know, did we do a good job and did you guys see any change?
I think that would be a valuable question. And then also, are there still safe pharmacy practice issues that I'm not in pharmacy, but I'm not hearing about since I'm not in pharmacy, that would be beneficial for me to know as a board member.
And I just want to make sure like we had those issues before and those issues are still going to be today and it's going to be tomorrow too, until we fix the root cause of it. And the root cause, I don't think so. We can fix it at the board of pharmacy level. So that's fine. Like if you guys want to send a survey, I'm not opposed to it, but I would like to know what survey we are planning to send to licensee, assuming that to license.
Okay.
Yeah.
Thank you. Board member Hemmons?
Board Member Hemmons, oh goodness. So there was a survey that was sent out to licensees, which included this subject, right? Am I correct on that?
It was about this specific subject, safe pharmacy
Okay.
practice.
Okay. Safe pharmacy practices. What has been done as it relates to the outcome of that survey that was sent out before?
So the whole presentation Mr. Runyon just did went over the process of what happened with the survey, what the work group did with it, what rules were promulgated from it, and what rules passed from that.
Okay, so there's still things left to be done.
No, ma'am, we finished that. The remaining things were not felt to be big ticket items that needed to go to making policy review. The question remains that it's still on our strategic plan as one of the pillars of importance to pharmacy practice, and whether or not we want to give direction to board staff about doing something at this time regarding safe pharmacy practice.
Okay, so where did the issue of a survey come into play this time around? Because I thought I heard that one of the questions
It's part of our strategic, it's part of our strategic plan. We have to go back to each.
Okay. All right, so that's
following through with all of our stuff that we have been doing.
Okay, so that's where I'm going with this. Why do we keep surveying people and then getting a response and then we're not really doing, fulfilling or addressing all of the issues that comes up on the survey? Why do we keep doing surveys then?
So we did all of the ones that were felt to be important by the work.
Who made that determination about what was important and what wasn't important?
The work group that Mr. Runyon had on the thing, the different people, the different licensees, the different subject matter experts who were on the work group, they are the ones who made the determinations.
Okay, so what's the feedback loop then to the people the licensees who completed the survey?
The
What's the
feedback
feedback to them to let them know, hey, you know, this work group decided that this wasn't important, so we're not going to do anything with it.
Staff member Runyon, board member Hemmings, I'm not sure I follow, the statement that we didn't do anything with it because
Okay,
I
because,
highlighted
okay,
several rules that were
I just
implemented
heard,
and as a
I just
function of
heard
that.
President Ching just say that there were certain items on there that the work group decided was not going to be addressed. So my question
That was
is,
part of the presentation that you just saw.
I couldn't listen, I couldn't hear that. It was so much information. It was an overload. Just too much information at once. But did you not just say that there were items from the result of that survey that the work group decided would not be addressed? Isn't that what you said?
Mr. Runyon, could you go back to the slide, please?
Staff member Runyon, yes, I'm having staff member Melvin pull that up. And while staff member Melvin's doing that, I'll just read part of the registrants pillar and the selected actions that are in the board approved strategic plan. And it says study and propose ways to ensure access to medications and pharmacy services, continue and enhance the safe pharmacy practice conditions initiative. Those are under selected actions, and then progress indicators. Also mentions the SPPC. It says provide regular updates on discussions and outcomes of the Safe Pharmacy Practice Conditions Initiative. And board member Hemmings, I think this is perhaps what you're referring to. The highlights show areas where rules were drafted and adopted. And just like the rules, the policy topic ranking list from earlier, there are things that have been done or actionable items that resulted from certain aspects of this or certain items that were ranked, and then there are those that were not. So perhaps that's what you're referring to. The items that aren't highlighted would still arguably represent items of opportunity for future rulemaking, whether or not another survey is launched. Does that answer your question?
I guess, yeah, I guess, you know, what I'm trying to say is that people take the time to complete these surveys. And I think it's important that if there are there's feedback and results in that survey, that whatever group or entity decides, you know, they're not going to do anything about, that there needs to be some feedback to the licensees as a collective when that decision is made. And I say that to say, if you're thinking about doing another survey, are you going to change the questions on the survey? Are you going to ask those same questions again? Because if you're going to ask the same questions and people are going to give you a response that you're not going to follow up with, what's the point?
Remember,
So I don't know.
this is board member Chin. Just like when we did our rank thing, it didn't all flow with how you work on policy, but the things that were in the lowest rank, not everything gets addressed on every survey. I don't think that I've ever taken. But the board also puts on their website and puts in their communications to all licensees information that work groups have done. And they all have access to, I think you all were doing lots of communication to licensees when you were doing workplace safety issues that I recall. So communication is going back to licensees. It's not like go ahead, board member Kroger.
Remember Kroger, I think there's maybe a bit of confusion on the surveys. There was two surveys, one that went out to all licensees. The result of that survey was the formulation of the work group. The second survey that had the items that weren't quote unquote addressed, that was from the internal survey of the work group and the prioritization of types of rules or changes that work group then used to inform the board for decisions. So it wasn't that the general licensee surveys, they did not get feedback on items that they had wished for. This was the 10 or so individuals who were part of the work group that provided this information. And there was a survey within that work group. So I think that's where maybe there's a little bit of confusion on the surveys. And I think, I don't know if that helps board member Hemmings understand, like, these items that were highlighted were addressed since that work group, but it's not in direct, like, it's in relation to the broader survey given to all licensees around workplace conditions, but it's that general process of gathering data, a work group or a rules advisory committee informing the board and board staff on future rulemaking. So, board member Hemmings, I appreciate and totally understand that, like, hey, if I took a survey and I never heard back from it, like, what's the point of doing that survey? So I hear you on that, but I think this process is typically kind of like the rulemaking process. And I do feel like licensees were informed that there was a work group that was happening in result and decisions were made in result, but the pharmacists of Oregon did not rank these items broadly. It was those who were participating in that work group.
Thank
So
you.
this was the work group that was selected by whom? You know, forget it, move on, it's fine.
Thank you. Board member Beeman.
Board member Freeman, from I understand this is part of the strategic plan, one of our pillars. From a from what we were talking about earlier in terms of moving along and not trying to confuse things, I think that maybe focusing on more pertinent regulations might be where we spend staff's best efforts. I am very passionate about this topic. I think that regular surveys of this sort, just to so that the board can have a gauge of the actual practice conditions, is really important, no matter what the pharmacy world is like at that time. But it's always evolving, and so it's nice to have kind of a gauge of that. However, I don't know that it should be our top concern, given that when we, no matter what the work group said and no matter what, high level items wanted to be in the work group, when it boiled down to it, it comes down to the payers and where the money's coming from to resolve most of these issues that I don't think we as a board, we don't have control over. And I think by implementing more restrictions on outlets, especially small businesses in Oregon, and PICs and pharmacists, and a lot of it kind of boiled down to more boxes to check. Otherwise, your license is in jeopardy. And I think that's a not the best approach to improve the conditions for patients and for pharmacy licensees. But I think keeping this in the back of our minds and having a licensee survey of conditions periodically is not a bad thing, just to kind of find the pulse of pharmacy at the time. Thanks.
Thank you. Board member Chin, if the purpose of doing survey was to just get a pulse but not do a work group or do action, I'm just trying to think of who would be the staff person who would aggregate that data to bring back to the board, and then would we want to make decisions on whether or not we need a work group at that time? And then where on that previous plan of what's in the immediate, high, medium, high and low priority of what we need to get done. So I think those are, I don't think we need to make a decision today about whether or not we want a survey, or are you just asking for feedback right now? We don't need to make a decision today, so. But it is on a strategic plan. This is our update. Board member Hall.
Board member Hall, I'm also passionate about this I don't know if the survey is gonna help other than compare where we were and where we feel like we are now. It is nice to feel like the board cares when you offer a survey about, things like this. But I will say that workplace safety currently is poor and mental health for healthcare professionals is not that great at the moment. I mean, we barely have enough trained sterile compounding technicians. We're always short-staffed and it's scary at times. So, but as far as the survey goes, I don't care either way.
Thank you. Board member Kirkbride. Board member Kirkbride, I do support regular surveys, so I don't know if that's every 3 to 4 years to kind of keep a pulse on what's going on. I do think no matter what, you're always going to get a mix of things that this board can do something about and things that are a function of the business of healthcare, which we cannot fix, as we know, and is rapidly changing every day in our current environment. So we are going to get things that we can't take action on. The one thing that I had curiosity about, and it's actually cut off, is I think the number one ranked thing was e-prescribing mandate. So that being number one, and I don't see it highlighted, and you showed the map, and we're in a group of very few states who are not doing that. Is that something we can do something about, or were there barriers? So I guess my ask would be if that's something that can be worked on, that would be where I would say we go next, because it was the number one rank and we seem to be lagging behind as a state.
Noted, and I don't have the answer to that. Board member Kroger?
Board Member Kruger, thank you again for putting together a thoughtful presentation and taking the time to do that. Once again, I'm asked to give my gut reaction to a presentation and a topic that was vague on this agenda. And if it's not clear, I'm not thrilled that this is how we approach these meetings when it comes to there is no clear objective, there is no pre-work, there is no understanding of what I as a board member am being asked to consider. I think that going through the strategic plan and providing those updates as the board had determined through their strategic planning is great. I think it just needs a bit more thoughtful planning as how it's presented to the board, and that we are thoughtful that we aren't picking and choosing certain parts of the strategic plan to focus on, and that there's a methodical way we go through that if that's how we want to spend our time. When it comes to safe pharmacy practice working conditions, I too am passionate about this. It is a multifaceted issue, and in some ways as a board, we can regulate and monitor, and then there are many aspects of it that are within our purview as the board. I think I look to other states where they have patient code of conducts and the abuse that our pharmacists, especially our frontline pharmacists, our community pharmacists, receive from patients. I would love to see that addressed here in Oregon. Our pharmacists, our technicians do not deserve to be yelled at, screamed at, threatened, put in a position where they feel rushed by the public to provide the services, and the board taking a stance on how we support our pharmacists, taking the time that they need to safely deliver pharmaceutical care, I think would go a long way with the pharmacists and technicians. I think the hard truth is here in the state of Oregon, it's very hard to operate. We've had discussions today on the complexity of our rules, the amount of our rules. I think probably more anecdotally, in my experience, licensees are afraid of the board. They are afraid that if they take a step in the wrong direction, they will have permanent discipline on their license. And they are good pharmacists and technicians and good people who are not quote unquote bad actors because they made a singular mistake. And I still am very passionate about patient care and patient safety in this role. I think the good work that the board has done in response to the survey completed. I don't know if anyone actually realizes this, but I was part of that work group. So I recall the conversations and the ranking and how that went forward. And I think the pharmacist autonomy piece and the board supporting our pharmacist professional judgment is a welcome relief for pharmacists. And I think we can continue that good work here at the board in supporting our pharmacists and our technicians and their professionalism when caring for patients here. As far as another survey, I've got strong personal opinions about surveys because, I mean, you're asked for a survey just about every retailer you go to, right? And I think that it does provide an avenue for those who are upset or frustrated and feel like they have no other avenue to provide feedback. But you don't often, it's human nature that if somebody meets your expectations, you don't necessarily provide that good positive feedback either. So a survey, if that's the group's, you know, that's fine, but I think there's inherent problems with surveys. Right, you said only 11% of the thousands of licensees actually responded to it. So you have to understand that there is inherent issues with broad surveys, especially regarding this topic. So thank you.
This is Board Member Chin. When you talk about that, they took off the patient feedback as part of our provider pay because it is the people who are angry who do more of the feedback than the people who are happy doing the feedback. And so it was something that was removed as a, you know, where you get your pay. It was connected to pay, and they figured out that it wasn't a worthwhile survey for connecting to that. So I agree with your comments. Board Member Benito, did you have anything else that you wanted to add?
How was the board, sorry, board member Beal, how was the survey sent out? Was it, I can't remember if it was during COVID and nobody had a brain then. Was it just an email that was sent out or was it attached to the license? Because I remember the one that's attached to the license that we have to pay for. That one I know.
Can we take Board Member Hemmings, her hands up while I look it up for you really quick? I'll find.
Member Hemmings?
I was just going to agree with what board member I forgot. Board member who spoke just before.
Okay.
Kroger. Yeah. That was my point that I was trying to make. Thank you.
And while you're looking that up, I think, I don't know that we have any specific direction today, Gary.
Hello, could I ask for that this information could be presented in a different way in the future?
Staff member Runyon, I'm open to suggestions as always. You know, anything in particular in mind, or what would be the goal of that?
It was just a lot of information all at once, and I felt like there was this pressure that a decision needed to be made, whether that was intended or not. Is it possible that this information could be shared in advance? Could it be broken up into smaller pieces, sections?
I think that it would be nice to have the information ahead of time to be able to have some idea about forming questions and having conversation. I don't know that this could be any smaller. It was a succinct presentation of the timeline of what happened. But I think maybe if you could see it and have time to absorb it prior to a meeting, that might be helpful.
This is Board Member Patel, and I also agree that, is there any way we get this so much information, but can we get sort of like, what is the purpose of this presentation? You know what I mean? Yes, I see that presentation, but I didn't know what we supposed to do, or what information you are looking forward from us. So even the standard of care, right? There's a statement, there is a semaglutide statement, but I want to know, like, hey, we are giving you this presentation. This is the objective, and what we want from the board members, like for this work group policy presentation, right? So it's like, we are going to ask you, like, do you want to send out the survey? And if you say survey on what topic, to whom, and what's the outcome? If we get the survey, what we want to do with that survey. I think that would be a little bit more helpful. Thank you.
Thank you. Board staff, Avramov?
Staff member Efremov, I think this is a really great discussion, lots of feedback, and we greatly appreciate it. I think just one point of clarification too. So the guidelines we were given from the board previously was that anything that needed mailing related to rules and cases and other information needed to be provided the Monday before the board meeting.
By noon.
By noon, and anything else that needed to be a PowerPoint or presented in real time was okay to do. So we have been following what board direction was. If you would like to change that, that would be good to know. And secondarily, the information that was provided today was discussed at the last board meeting as the directive, and we could do that more clearly in the future too, of how it aligns. I don't know if you remember, we kind of had a template before that the previous consultant would share kind of the objective of it, how it related to the strategic plan, what pillar it was, and a little more information to help guide the initial conversation. But I think what's different in these situations than previous ones related to rules, there weren't really actionables needed, other than we said we would bring this back to the board. There's new board members, so this was really just trying to level the playing field, right? So everyone has the same information to be able to have informed discussions. And at any point, if you want things added to the agenda, any board members can email the board president and ED to ask for that to be on a future agenda. These items weren't intended to be the one and only discussion. This was just information to make sure the board could then make informed decisions in future discussions. So I really appreciate the opportunity to clarify that. Thank you.
Thank you. That was helpful. And I know that particular standards of care we've talked about, and this was more of an information more than an action. It was definitely not an action thing.
Board Member Kroger, Bree, can you, repeat what you said about, I get the compliance cases, the board staff would get to the board members at a certain date, and I just didn't track what you said about the other items.
Yeah, so the board, staff member Efremov, the board previously has given staff direction that any mailings related to rules needed to happen the Monday by noon before the board meeting. And any PowerPoints or other discussions in real time could be presented in real time and did not have to be mailings ahead of time. So if the board would like those things ahead of time, we might need to adjust our agendas a bit, because we do have a lot of other competing deadlines on things that we have to provide. So being able to support and give all that information, you might just need to kick it down to a future board meeting sometimes. If you need that 2 weeks ahead, or you need it the Friday before, we will adapt to whatever the board is requesting. Just would ask, to be able to have that clarity and communication. Thank you.
So do we need to decide on board direction to board staff on mailings, and it would be hopeful for having these meetings move forward.
Board Member Kroger, my expectation going into these meetings is that that I'm able to understand what the agenda is and what is the objective of each agenda item, right? And these were one line items on the agenda. You know, I could glean from the topics in general, what we were going to be possibly discussing. And totally understand that, you know, the board staff is working right up to the wire on the presentations, but I think in order for a smooth facilitation of the agenda items and the conversations that we need to have, even if it's in draft form, we need those ahead of time. We cannot continue to be put on the spot to give our gut reaction and direction to the staff, because I don't think it's going to be well informed or well thought out. And maybe we go home one day and, you know, go, oh gosh, I wish I had spoken up or said this or the other. I think that's not what I don't want to do that. I don't want to, you know, have an afterthought and then, you know, be like, well, too bad, ship has sailed. We're out of the ability to provide that feedback. So, and I would think a little bit, like, I get the rules. These topics were related to rules priorities, how we write rules, standard of care. I get that they weren't actual rules, but these are all related to rules in general. And I think that the importance of the board, my opinion as a board member is I need time to digest so that I can provide the staff with my well-informed guidance and decision that way. And I won't speak on behalf of the rest of the board, so.
Remember me though, I appreciate if it's an FYI for those of us that are new and that this is what has happened. But prevent all of the round robining and opinions and questions, if at the beginning or at some point President Chen or someone will state, this is just for your information, like no comment is needed, no discussion is needed. This is just for you to know so that we're not wasting board staff's time and members' time and public's time on an item that was just meant as an FYI. Thank you.
And this was more than an FYI. There was an opportunity for discussion, which we did have, but I don't know that it provided any potential feedback for board direction, but I think that particularly there were board members who did not understand standard of care and what that was, and so this was an opportunity to have more of an education about what standard of care has been and is in some states and history of it. Not necessarily a direction to head that way. This time, don't know. But I understand the frustration. I understand that what I'm hearing is that moving forward, to have a robust discussion, if one were to have a robust discussion, we need to have the information ahead of time to be able to, I'll just call grokking it, but to be able to really consume it and chew on it before we can have that discussion. So I think, does anybody have a disagreement about having more information in your packet?
This is board member Patel. I'm just going to agree with whatever board member Kroger said. And yes, I'm in the favor having this information ahead of time and a little bit more kind of objective and outcomes, what we are trying to achieve. Thanks.
Any other questions?
Member Hall, I agree with what's been said, and I was confused why there was no readings for those. And I do personally like to digest information and think it out and have, you know, something smart to say instead of just coming off the top of my head. So.
Member Kirkbride, did you have anything to add?
no, I don't mind giving a gut reaction, so I took this as kind of like, what do you think? I didn't take it as this is your only opportunity to give an opinion, so I didn't have that feeling. But I do agree that having more things ahead of time is always helpful. And I think especially if you are going to ask us to contemplate questions, some of those slides were like, they went through them so fast. And then by the time it was my turn, it's like, I don't even remember what it said on the slide. And we didn't get, so I could have been looking at that if I had it and been a little bit more prepared. So I think it's always helpful. I would not want to see, so let's say you're giving us a update on the strategic plan. You're not really looking for board input and it delays it to another board meeting because you couldn't get it out in time. Like, I don't want that. I don't want things to be delayed. But I do think if you are interested in our opinions or take on something, we do need to see it ahead of time to formulate those thoughts.
Action given.
Staff member, could you give us a timeline though for a deadline? It's really important for us to have hard deadlines, just so we're on the same page. We don't have to revisit, like everyone had a different expectation of the conversation of what earlier meant. Is Monday at noon early enough for all documents that will be presented or provided for any decision making? Or do you need it sooner? Thank you. Remember Kirkbride, I prefer things come together. So it does throw me off when like one thing comes and then a few days later something else comes and then a few days later something else comes. So for me, the preference would be whatever that deadline is, that stuff comes at once and then I can go in my allotted time and look at it. That's my.
Member Hall, I'm fine if things are added later, I don't know, 48 hours before the meeting or Monday at noon, that's fine. I just want an email telling me that there's new stuff.
Which I think we always get. Yeah, that's very helpful.
For Marjorie's, Monday noon is fine with me. You know, when there is new stuff, it says revised, so we're made aware of it. So.
Is anybody uncomfortable with Monday at noon?
This is board member Patel, yes. Monday noon, no, because I have like Tuesday, like travel whole day. And I agree with the board member Kirkbride. Should be sent at one time. There's no more addition. It's kind of, it threw me off too, because I download and read everything, make comments. So, and for me, I think at least 1 week. So it's like meetings start on Wednesday, then the before 7 days, it should be, it should receive all the material, because sometimes we get way too much material. And if you want to do good job, for me, I cannot speak for everyone, and for licensee, because licensee, they also have, job and life and family and everything. So I feel like if you want everyone to engage, everyone to do a good job, I think it should be 1 week, and that Wednesday noon is just stop. Then you have a whole week that you can plan. If something emergency happens, still you can manage the board meeting. That's just me though.
I think that there are sometimes cases that come after that date, but it's not like the whole case load.
I would
I think we can.
For cases, I understand. Okay, so if the
Okay.
case, if the 1 or 2 cases, like definitely I understand.
Okay.
But the material needs to be present in the open session to the licensee, and then board members have to make a decision. I think just the Monday afternoon for me to do my research and everything, I don't think so that's enough for me. It should be 1 week to do the research, get informed, and make a informed decision. Thank you.
Thank you.
Staff member Uppermoth, maybe just one trying to hear everybody's opinions and try to come to like a middle ground related to workflow and not to inundate you with multiple mailings too, because I know that's super difficult to track and revise and how things are stored in the technology you have. It's not the easiest to work with. So trying to be mindful of all those things. We do first mailings 2 weeks ahead for cases, right? And then we do a second mailing if there's other cases or things that happen the week before as second mailings. So if we list it to 2 mailings only and get the first one by 2 weeks ahead and then get the last one by the Friday before the board meeting, so you'll have the weekend to review, would that be okay for all board members?
Member Joyce, yes.
Remember Jen, yes.
Remember Binetto, yes.
So this is board member Patel. When you say weekend before, you're talking about mailing or you're talking about mailing and the cases?
Member Uppermoth, I apologize. So it would be like first mailings and second mailings. So everything would be provided to you with the intent that all of the cases hopefully would have been provided before, but there might be one last mailing. That would be the Friday before the board meeting. So all mailings technically would be complete by the Friday before the board meeting. That next Wednesday.
With the exception of legal advice, that's a carve out.
Okay, so what I hear is Friday, yes, I can, that's doable for me. That still I have weekend. If that's what work with other board members, then sure, Friday.
Staff member Uppermoth, because honestly, the intentionality here, if we can't get you materials in a way that you can be thoughtful in your approach and give us thoughtful feedback, that diminishes the whole process. We want to make sure that we can meet you where you're at. We also want to be able to produce what you're asking of us. So I think this dialogue back and forth is wonderful and appreciate the opportunity to have it. Thank you.
Okay. 2 mailings, 2 weeks before, Friday before. Reading. Good conversations. Are you ready to take a break? 3:40 or 15 minutes.